everyone. Today I am going to present the chemotherapy and radiotherapy for the portal vein thrombosis in SCC. Now I will start with introduction, radiotherapy in SCC with portal vein thrombosis, chemotherapy in SCC with portal vein thrombosis, targeted therapy and immunotherapy in SCC with portal vein thrombosis, radioimmunotherapy in SCC with portal vein thrombosis, and some IL-based data which I have published. As we know, the liver cancer is the 7th most frequently diagnosed cancer. It is the 3rd leading cause of the cancer-related mortality. SCC 85% of all cancer, and etiologically it is induced by viral hepatitis, alcoholic liver diseases, NAFLD, metabolic and NASH. सर मुझे इस पर ढंग से दिखता नहीं है.
कॉलर माइक दे दो, उधर जा सकते हैं, फिर उधर से
कॉलर माइक लगा. If we look the current overview of the management, it is guided by Barcelona liver cancer staging system, which is based on the tumor burden, liver function and performance status. It has been divided to the various stages, like very early stages when the lesion is less than 2 centimeter, preserved liver function and performance it is good. Its early stage A, the single or 3 nodules, each nodule less than 3 centimeter with preserved liver function. Intermediate stage B, multinodular and presented with the liver function with good performance status. Advanced stage C, when portal vein invasion or extrahepatic spread and preserved liver function with performance status 1 or 2. Terminal stage D, any tumor burden and end stage with lower function, performance status 3 to 4. This is the classification of Japan liver cancer study, which has been divided on the involvement of the portal vein sites. This is VP1 tumor thrombosis to the distal to the second order branches of portal vein. VP2 is the invasion of the second order branches of portal vein. Third is the thrombosis in the first order branches. VP4 is a tumor thrombosis in main portal vein trunk, the portal branches to the primary involvement lobe or branches. And the VV1 is the tumor thrombosis in the branch of the hepatic vein. VV2 is a tumor thrombosis in the main trunk of the hepatic veins, and VV3 is the thrombosis reacting to the right, reaching to the right atrium over there. This is the update of BCLC prognosis and treatment recommendation. The treatment recommendations are generally followed up according to these programs. This is also updated program of INSL consensus on management of hepatocellular carcinoma. Radiotherapy for SCC with PVT. My teacher was saying when I was a student of MD radiotherapy, he was saying always that it is a very advanced modality with fine art of healing and provide best palliative care. It was 1984. He gave this information to us, and we learned that it is a very fine art of healing. It is very precise and effective radiation treatment delivery with minimum harms to the normal tissue, can be implemented by SBRT, IGRT, VMET. There are different ways of delivery of treatment. It can be treated by proton therapy or TAR also. So now the role of radiotherapy in PVT, radiotherapy particularly SBRT can be effective treatment for PVTT, especially in case of hepatocellular carcinoma. It lead to recanalization. Radiation therapy can lead to recanalization of the portal vein, meaning the vein can be reopened and which improve the blood flow and potentially reducing the portal hypertension. It can downstage. Radiation therapy can also help in shrinkage of the tumor and reduce the extent of the thrombosis, which can make it either to remove the tumor surgically. Combined therapies, radiotherapy is often used in combination with other treatment like TACE, TEAR, SIRT, radiofrequency ablation or surgical resections. It can be also used as a palliative care in case where there is a complete cure is not possible. Radiation therapy can be used to palliate the symptoms with improved quality of life. The effect of radiation varies with the effectiveness of the radiation therapy for PVT can be vary depending on the factors such as the extent of the thrombosis, the patient overall health and type of cancer. Emerging therapies, there are ongoing studies exploring the use of radiotherapy in combination with other therapies like immune checkpoint inhibitors and anti-angiogenesis drugs for further improvement treatment outcomes. This is a very important study, randomized trial, which was conducted by Laura Dawson and published in 2024. In this case, total 177 patients were treated, out of which SBRT dose was 27.5 to 50 GY in 5 fractions with sorafenib 400 milligram BD versus sorafenib 400 milligram BD alone. 74% had vascular invasion. All patients of SCC, out of which 74% patients were having PVTT. Closely early A plus B relapse replaces sorafenib as a standard care of for advanced SCC. Overall survival was 15.8 months and 12.3 months. Progression-free survival was 9.2 months versus 5.5 months. Microvascular invasion subset, the disease control rate was 75% as 45%, and overall response rate was 38 versus 9%. Similar grade of toxicities was in both arms. It improves the quality of life in 35% versus 10%. This study is the most popular because previously radiation was not used in journal to treat the liver cancer, and the introduction of the SBRT led to drastic changes in the treatment scenario worldwide. This is another study in which 160 patients were taken, 73.1% was treated with hypofraction. Hypofraction is the process by which we treat the tumor mass with conventional radiotherapy that has higher number of fraction, while 12.5% was given SBRT. Mean biological effect dose was 49.6, which was found to be a very effective, either deliver from hypofraction or SBRT. Median follow-up was 8.2 months. Overall survival in one 2 and 3 years was 39.6, 17.1% and 9.9%. Overall responders to primary and portal vein thrombosis was 74%. Non-responders was 26%. Now, there are many systemic therapies has come out to treat the liver SCC. Now, the chemotherapy was previously tried in early era. When I was a student, no specific chemotherapy was advised to give in SCC, but these are the few drugs which were used after 84, 85, the cisplatin and doxorubicin, cisplatin with methotrexate and 5-FU, cisplatin with apirubicin plus 5-FU, cisplatin plus doxorubicin plus capecitabine, cisplatin with capecitabine. Now, after cisplatin, gemcitabine base were also used, gemcitabine plus cisplatin, gemcitabine plus pegylated liposomal doxorubicin. None of these chemotherapy were effective. So, generally their use is now stopped, and in very few cases of hepatocellular carcinoma, like fibrolamellar carcinoma and sarcoma, these chemotherapies are allowed. Otherwise, the chemotherapies are almost obsolete in SCC and portal vein thrombosis. Next. Now, systemic therapy in TKI era, the currently used is sorafenib, levodopa, regorafenib, cabozantinib. These are some important TKI which are now being regularly used for portal vein thrombosis and SCC, with SCC. Next slide. So, systemic therapy, this is the NCCN guideline to use the targeted therapy and immunotherapy current guidelines. The first line systemic therapy which was preferred regime is atezolizumab plus bevacizumab. It is the first order targeted chemoimmunotherapy. Second line is, थोड़ा मुझे प्रॉब्लम हो रही है उच्चारण में, ठीक. This is the first line and this is the second line, and sometimes when this is also depend, they are also recommended with AFB is more than 400. So basically sorafenib is a multi-kinase inhibitor, rational for the use in SCCs, cellular signaling that is mediated by RAF1 and VEG pathway has been implicated in the molecular pathogenesis of SCC. This is called SHARP trial, which was introduced in 2008. In this, median overall survival was 10% versus 7.9 months. Lenvatinib, it is a multi-kinase inhibitor, targets vascular endothelial growth factors. It targets 1, 2, 3 fibroblast growth factor 1, 2, 3 and 4. Evidence, this is a REFLECT trial which was introduced in 2018. For median overall survival with levodopa versus sorafenib, this is a comparative study. In this, 13.6 versus 12.6. These are another trial, celestial trial. There are new TKIs which has been tried since 2016 to and showing the various results. Next slide. Immunotherapy in SCC, there are long list of immunotherapy. Their mechanism of action is PD-1 predominantly act as a brake on more peripheral local immune cells, that is tumor infiltrating lymphocytes and other immune cells. In response to PD-L1 and PD-L2, which were mainly expressed by the tumor cells and antigen presentation cells. CTLA4 predominantly acts as a brake, more often centrally located immune system cells like lymph node in response to T cell receptor engagement and CD28 co-stimulation. Monoclonal antibodies targeting PD1, PDL1 or CTLA4 relieve the brake on suppressed T cells and unless their anti-tumor immunity against cancer cells. This is a way of acting of various checkpoint. This is a mechanism showing which I have explained in the previous slide. Next. What is immunotherapy do in SCC? Basically, it enhances the immune system to target and destroy cancer cells, BCLC, BC, and unresectable to metastatic disease. PD1 inhibitor are following pembro, nivolumab, dostarlimab, PDL2 inhibitor, atezolizumab. I think all have common MAB. They are all also called MAB therapies. Landmark study for this now in practice are number one. This is a CHEMOTHERAPY trial 2459, which was conducted between nivolumab versus sorafenib as a first line therapy for advanced the nivolumab arm shows 16.4% response, while sorafenib shows 14.7% response. Median progress free was nivolumab with 33.7 and sorafenib 3.8. Now it is predefined threshold for statistical significance of overall survival with nivolumab not met, although nivolumab demonstrated no clinical benefits. Overall, nivolumab 15% of sorafenib. It is a failed trial, which is not being used today. Next, it is a key. These are the keynote. This is the keynote trial to 4 phase trials, in which overall survival was 17%, median was 12.9% month. Who also granted accelerated approval from US FDA in advanced SCC treated with sorafenib. Another is keynote trial, which was a phase 3 trial evaluating pembro against placebo in Asia in 43 patients with the advanced SCC previously treated with sorafenib and showed a statistically significant survival benefits. There was significant survival effect over sorafenib. This positive trial results confirm the role of single agent ICI as one of the treatment options in second line setting after failure of TKIs. This is very important. Imbruvica trial 1.5 is now in practice. In this, atezolizumab with bevacizumab versus sorafenib in unresectable hepatocellular carcinoma. In this, overall survival 12 months was 67.2%. When compared with sorafenib, it was 54.6%. Median PFS was 6.8. With sorafenib it was 4.3 months, and grade 3 to 4 adverse effect was 56.5 and 55%. Next. Is also showing the median overall overall survival atezolizumab plus bevacizumab 19.2%, while sorafenib was only 13.4%, and median progress-free survival was 6.8, and so with sorafenib it was 4.3. Next slide. This is the most popular trial which is going on nowadays. It is STRIDE regime. Next slide. In this, it is a multicentric phase 3 trial. It is exploring the safety and efficacy of durvalumab PD-L1 inhibitor plus tremelimumab TLA4 inhibitor versus sorafenib in patient with advanced SCC, patient who has not received prior systemic therapy and also not eligible for local regional therapy. So this is a most popular trial which is now in use. Next. Demonstrated non-inferiority of the durvalumab to sorafenib as first-line treatment in advanced risk cancer. Combination therapy was associated with higher overall response rate 20% versus 5%, and 3-year overall survival 31%. All the similar medial PFS. Recently, FDA has approved tremelimumab in combination with durvalumab for unresectable carcinoma of hepatocellular carcinoma. This is of 22 publication. Next. This is the evaluation of systemic therapies in estimated therapies in advanced hepatocellular carcinoma. It started with sorafenib to levodopa to nivolumab, then atezolizumab, bevacizumab, etc. Next. This is also the journey of second-line treatment, which began from 2011 onwards. Third. Now, this diagram showing the tumor burden. If tumor burden is this, then you can found in a very early stage and intermediate stage, the intra-arterial therapies are useful. When the very early stage, the surgical percutaneous therapies are very effective, and in immunotherapy, they are the available immunotherapy which is available, and these are the under investigation immunotherapeutic agents. Next. My basic subject starts with combination of radiotherapy and chemotherapy. Our role of radiotherapy with chemotherapy started very late. The rationale of radiotherapy giving was significantly influenced the tumor and host immunological microenvironment. It increased expression of major histocompatibility compatibility complex class 1 molecule on tumor cells. It enhances the visibility and recognition of the cytotoxic CD8 T cells. It promotes the intratumoral infiltration of cytotoxic cells. Dendritic cells are activated, release of pro-inflammatory cytokines, and upregulation of the co-similarly molecules. DNA damage leads to induced high mutational and neoantigen burden, tumor death. It enhances the PD-L1 expression in tumor cells via FNY and stated 3 pathway, may also induce immunosuppressive environment, recruitment of regular T cells and tumor associated macrophages. Next. Immunotherapy and immune checkpoint inhibitors disrupt the cellular interaction between PD-1 and PD-L1, CTLA4 and B7-1, CD19 and B7-2 CD. This promotes the T cell activation with anti-tumor properties. This has been discussed by Dr. Gayatri many times, but radiation part was not included in this. Next. These are the different pathways how radiation therapy enhances activation of the infiltration of the immune cells to the TME, the cytotoxic cell upregulate the. This is the graphical representation of effectiveness of radiotherapy with the ICI and TKIs. Now it is very difficult to optimize the timing of ICPI during radiotherapy, which is still a debatable subject. Young et al. And NTCLA4 before RT is more effective to reduce T ranks. ICIs before RT primes the immune system and which enhances the recognition of the human antigens released during the subsequent RT. RT before ICI modules the tumor microenvironment and enhances expression of PD-1 and more effective for ACIC. CT is also known as cytotoxic T lymphocyte associated protein. Like
Dr. Hanuman,
Sir.
can you summarize, because we have a second presentation, I think, by Kanika. Can you
Sir.
summarize?
बड़ा ना गया.
Just give your protocol if you have any. Yeah, you can give
ILBS data.
Yeah.
So this is our recently predictive factors nomogram presented by our department by Dr. Deepti. Basically, the PIVCA was taken as a median. When PIVCA is higher, the response is poor. While PIVCA is lower, the response is comparatively good. So we have included many factors in this, like the tumor is multifocal, when albumin, what is the level of albumin, whether PVT was involved, what was the bilirubin level, how many is the lymph node. Next. This is also paper published by ILBS in which 24 liver limited cancer disease were taken. In this median overall survival was 10.9 and 6-month overall survival was 75. Next. This was the treated in this case was treated in ILBS. This is the initial stage in this. Test with SBRT was given with TKI. Depth test at 6 weeks. TKI after 3 months of the radiation, we can see the response, and after 1 year of the TKI and depth test, there was a very good response, and patient survived for about 3 years. This is a very good case that sequential depth test with TKI can improve the overall outcome. Next. This is this was the first palliative role of SBRT in Barcelona clinic liver cancer. This was the first publication in which we have shown the survival as a palliative SBRT in liver cancer stage C epithelial cell carcinoma patients. Next. This is also SBRT radiotherapy for inferior vena cava. Nobody gives radiotherapy for inferior vena cava thrombus in epithelial cell carcinoma, but we have treated V1 4 cases, V2 5 cases, and V3 8 cases. In all these cases, median overall survival was 9 months. Local control was 80%, and 6 month overall was 75%. Next. This is the, in elderly patient we have treated, the age was high, the age was 75 years of the age. This is a recently published paper, but tumor size was 9.6 centimeter. Tumor in vein was 100%, nodal metastasis was 9, ECOG 1 was in 10, and 8 score was more than 9. PIPCA was very high, and LV score median was 2.29. This is data under publication that we have used SBRT with combination SBRT, where there is no PVT and with PVTT. The RT has a definitive consolidative treatment or salvage treatment for the progression, recurrence with other liver-directed treatment, and systemic therapy. With PVTT, 27%, without TV, 29%. The no PVTT median overall survival was 2.3 months. With PVTT, overall survival was 10.9%. So it is important, if there is no PVT, the survival is better than the involvement of the PVTT. Next, you like or not, but you cannot avoid radiation. This is my submission, and this was always told by my teachers who has taught me radiation in the beginning, and still I feel the radiation plays a very effective role in peace and war.